Good morning, everyone on the West Coast, and good afternoon for those of you on the East Coast. Hopefully, you're enjoying your lunch break, and thank you for spending that time with us. My name is Jason Fass. I'm going to be your host today for today's webinar. I'm one of the vice presidents at Canopy, and really appreciate all of you being here for a very important topic. The goal today is really to learn about the strategies that some of the leading health systems are using to mitigate workplace violence. And then we'll dive in a little bit into how technology can be a key part of preventing workplace violence. So let me quickly talk about the agenda. So we'll welcome our panelists here in just a second. We're going to talk a little bit about the overall challenge, and I think this will be something that's very resonates very well with this audience. We have a lot of nursing leaders on the webinar today from all over the country, and then we'll jump into some of those strategies that you as leaders can work with your teams and your staff to help keep them safe in doing what they do. And then, as I mentioned, we'll dive into the role that technology plays. And we have a live Q&A at the end, so you can add your questions into the chat. So without further ado, let me welcome our panelists here. First, I want to welcome Lisa Rowan. Lisa has an extensive nursing leadership background with the University of Maryland, where she was the chief nursing executive and vice president. She really brings a wealth of knowledge and understanding of the systemic safety challenges and many of the solutions. So, Lisa, thanks for being here. And to keep everyone on their toes, me in particular, we have another Lisa, Lisa Abbott, who's joining us. Lisa Abbott, who I may refer to as Lisa A, is the Chief Human Resources Officer at an institution that many of you will be familiar with, Boston Children's Hospital. She's also the executive vice president there. In Boston Children's, for those of you who may not be familiar, is a leading pediatric hospital. And Lisa spends a lot of her time navigating real-time safety demands of her staff and implementing, the really impactful solutions there. And lastly, I want to welcome my colleague, the CEO and co-founder of Canopy, Sean Sinha. Sean has spent the past 6 years now, I think, Sean, building this solution and a suite of solutions here at Canopy, and really dedicated to keeping all of the healthcare professionals in our country and around the world safe. So excited to have you all here. And let me just set the stage briefly on the overall challenge. So, of course, safety is top of mind for all of you. And while many people outside of the healthcare industry may not realize just how big a challenge workplace safety is, I think you can ask any nurse in the country, literally any nurse, and they're going to tell you it is a huge concern. So let's quickly just ground ourselves in some of the stats in the US today. Roughly 75% of all workplace violence incidents occur in the healthcare sector. And that's a staggering number in and of itself. But perhaps even more staggering or alarming is that 80% of these incidents actually go unreported. And so we're going to talk about that a little bit today. And I want to get both Lisa A and Lisa R's perspective. And one last stat that really jumped out at me in some research in preparation for this webinar is that in 2024, a nurse was physically assaulted every 30 minutes. Now, this just simply shouldn't be the case. And it's alarming, and it doesn't have to be the case. And so I was wondering, Lisa Rowan, Lisa R, with your system level perspective, if you will, how have you seen the nature or the frequency of these safety concerns evolve over the past couple of years?
The safety issues have increased. We know that in a recent study, 8 out of 10 nurses reported having violence perpetrated against them in some way in the past year. 8 out of 10 nurses. And 60% of nurses in a recent survey said that has caused them to think about a different job or leave their jobs. And so we have seen the incidents of violence increasing, and particularly increasing since COVID. And as you said, Jason, the underreporting is a huge concern. And that's why we really need to consider strategies to encourage nurses and all healthcare workers to report issues and events that happen.
Absolutely. It's really amazing to me that the incidents go unreported. Although after talking with so many nurses, I understand why, and I think we'll talk about that in a little bit. Sean, you founded Canopy 5 years ago, 6 years ago. Um, what have you seen with the technology lens in the industry?
Yeah, I think my view on this is that there's been two fundamental challenges. Number one, healthcare, just the practice of taking care of a patient is a very personal experience. It's a few individuals that might be in a room doing a procedure or interacting with a patient. And as a result, there can oftentimes be the sense that there's nobody else around. And during COVID, we implemented closed door protocols and things like that that made that challenge even more, acute. At the same time, you have a hospital behind you with a lot of resources that can actually help. And when we think about technology, we oftentimes in a healthcare setting, we often think about, hey, what's the new technology to take care of a heart or a condition that somebody has? We don't automatically think about applying technology to support our caregivers. And I think that was the biggest insight that we've really had over the last few years is that hospitals have lots of resources to support staff who encounter aggression and violence towards them, directed towards them. And at the same time, there's actually technology that can help get them support from that hospital, but the typical interventions and solutions that most are aware of come down to people and process.
Mm.
And what we found is that technology can make a difference. We don't anticipate the challenge going away, but there are lots of things that organizations can do that can make a difference for their staff. And we've really seen that over the last 5 or 6 years in the work that we've been doing.
Yep. Awesome. Um, okay, I'm going to keep us moving along. I think a lot of folks are here, as I mentioned, who are leaders within their systems and their teams depend on them. And so I really want to dive into this topic. And Lisa A, at Boston Children's, what are some of the core leadership strategies or cultural initiatives, if you will, that you prioritize or that you proactively put in place to enhance overall staff safety?
Thank you for the question, Jason, and it's a pleasure to be with all of your listeners here today. I think it's really important to recognize at the outset safety means different things to different people. There is certainly the physical safety that we're talking about, and the statistics are really staggering around how many frontline staff are, kicked, bitten, punched, spit on, and otherwise unfavorably interacted with, and that number has really escalated since COVID. We have, a number of patients, certainly in the children's space, that are staged somewhere where they can't get the right level of care. Think about behavioral health patients who are boarding in our emergency rooms or boarding waiting for the right bed in the right place, and the frontline staff, the nurses in those areas may not be as equipped as a behavioral health nurse who's trained in de-escalation and trained in navigating that patient differently. So there are some process and structural things that have happened, and truly the acuity of the patient population has gotten more severe over the last several years, in part because of COVID. So I think it's really important to listen to our workers, to listen to our nurses. We do that through surveys, we do that through rounding, we do that through different forums where we can just get feedback and know what's important to people. And then we need to act. Listening is a part of the equation, but acting is really I think without action, people, wonder if their feedback is falling on deaf ears. And so, there are a variety of things, and we'll get into some of them over the course of this conversation. But we've been really proactive in creating an employee bill of rights, right? A healthcare worker bill of rights. And just think of posters that stipulate how we expect our visitors and our families and our patients to interact with our caregivers, and what is acceptable conduct, and certainly more importantly, what's not acceptable conduct, so that we create a really visible expectation as soon as people walk in the door about what will and won't be tolerated. And as we talk about technology, there are ways to flag bad behavior in the patient record to help create awareness if becomes a pattern of behavior, and act accordingly. So really listening, responding, and being optically evident about what is and isn't permissible are a couple of the things that we've really worked hard on with Boston Children's.
That makes sense. One thing that I think is core, of course, to being able to listen is creating that culture where you're fostering a speak up culture, if you will. And Lisa how have you seen that done effectively, creating that culture where there's no fear of retribution and that your teams and your staff feel comfortable reporting incidents?
I think that it's incumbent upon leaders within healthcare, and in particular nurse leaders, to be very specific and intentional about asking the question of how have you been harmed or almost harmed? And once a nurse leader or a healthcare leader starts asking the question like that, it communicates to team members, oh, they're interested and they want to know the truth, the reality, and it's safe for me to say it. And as you have these verbal conversations, and they are eye-opening and enlightening to really understand the frequency of violence, how intimidated team members feel from patients and visitors, and sometimes from each other. And it then enables nurse leaders and all leaders to say, we need to know the frequency of this in a more realistic way. And we're asking you to help us be your best advocates by reporting these events and sharing them. And then leaders really need to do follow-up. They need to follow up on the different incidents as well as how the staff are doing, because to be an effective leader and to create a culture of safety and to create a culture where team members know that they're valued and feel protected is when leaders can reach out and say, hey, I heard about this. How are you doing? And I frequently made phone calls or visits to team members who were punched or had urine thrown at them or bitten or all of the terrible things that happen to team members. And I think one of the things leaders need to really fully integrate into their awareness and consciousness to take action is that violence occurs in healthcare 5 times more than all other industries put together. That is an overwhelming statistic. And when you know that, you can really focus on shaping a culture for safety. So as Lisa said, once you're hearing it, understanding it, then you also can focus on the types of things that need to be done, such as an assessment, a cultural assessment, as well as a physical assessment of what is happening in your environment. And the Joint Commission has a good outline for an assessment, and looks at, do you have the right policies in place? Do you have a standardized way of approaching things? Do you have signage? Do the visitors and patients and all members understand what the expectations are? What's the training like? How do team members escalate? And how are technological and physical safety measures put in place and integrated to ensure that team members aren't alone when an incident occurs?
Hey, Jason, I'd love to ask Lisa A and Lisa R their opinion on one of the nuances that I've come to really appreciate about this specific topic. One of the big learnings that we've had is that the kind of violence that occurs in hospital systems oftentimes gets directed at frontline staff as kind of the person who's the lightning rod for angst with the system or whatever struggles they're having. But sometimes it might be a side effect of something that they're going through that might be part of their care plan. How do you talk with your teams and your staff, each of you? I'd be curious to hear how you both think about this, or your organizations think about this. How do you talk to your staff about that gray area? What's accepted, what's not accepted? The unfortunate thing that I feel, one of the things that I feel like we've learned is there's almost an expectation that this is part of the job, when in fact it really shouldn't be. But where do you draw that line, particularly given the personalities of frontline staff who are there in the first place to take care of people and they feel like that's their primary job?
I can start, Sean. I think that's very insightful. And I think that it's great to, people want to hear we have a zero tolerance policy for violence. But the reality is, healthcare can't have quite a zero tolerance for violence, because the way we talked about it at University of Maryland medical system is it an organic reason or is it a choice? So if a patient has an organic reason, if they have dementia, if they are newly out of surgery and their anesthesia made them violent as they are waking up from it, or it made them confused. If their medication has made them confused and they're reacting in a violent way, those are things we need to understand and deal with compassion. And if a patient or visitor chooses to be violent, that is when a different set of expectations and policies can be used for people who make that choice to be violent. And it's hard in healthcare because we cannot put patients out of the hospital unless they are safe to be discharged. But we can have algorithms that are used for when we're in an urgent or emergent situation due to patient violence. We can put visitors out. And a lot of it needs to be thought through. It's not a perfect, it can't all be, this happens for everyone, but we have to try to make it as standardized as possible. But I think when you break it out between, is this something happening to a patient because of medication, anesthesia, or disease, that's different than somebody who's choosing to be violent and has capacity to make that choice.
I think that's really, really well said. I think the only thing I would add is this is where de-escalation training and leading with empathy really come into play, and really working hard to help create an environment where staff feel like working to de-escalate is not just what we're saying. We're really putting emphasis behind what that can do to neutralize a situation. Not every situation, but sometimes it takes a lot of courage to say, Sean, I need you to lower your voice so we can have a reasonable conversation. and saying that with your own calm, even though you may feel vulnerable in the moment. When we have families with the most vulnerable among us, right, our children, and that leading with empathy works well, not all the time, but it really works well to extend appreciation for the emotional state families are going through when they present with a sick child. And I think we do that well here at Children's. And again, just to reemphasize, teaching people how de-escalation works and how to apply it, and really practicing and learning that skill. And it is a skill. It can help in many situations. I agree with Lisa R. completely. There's a big difference between organic action and choice. And we want to create an environment where the choice to act well is one that outweighs the choice to act poorly. And sometimes we can control that. Sometimes we can't.
And I would tag on, Lisa, to everything that you said by also emphasizing that in addition to de-escalation strategies, we need to teach team members how to physically work with patients in a way that mitigates some of the risk. So for example, where is the door in relation to the team member? Where, if a patient is escalating, where are you going to put the computer on wheels in proximity to that patient? We had a patient take a computer on wheels and throw it through the window. And then he started trying to jump out the window. And so when those things happen, you realize that the things that we take for granted, and we take for granted that we got into healthcare to help people. And so it's a shock that these same people that we want to help may want to hurt us. We need to learn those physical strategies in addition to de-escalation strategies, and also what kinds of monitoring we can put in place, such as cameras or panic buttons or wearable badges. Because Jason, may I give an example of?
Please.
Okay. We had a car pull up outside of our emergency department, and a person, the driver, ran into the ED shouting, "My friend OD'd." And a nurse ran outside with Narcan or naloxone to help the patient in the back seat who had OD'd and was unresponsive. And when that patient came out of that overdose, as many of you are aware, sometimes people come out violent. Mm-hmm. And this person started strangling the nurse. So here we had an emergency department nurse outside of the unit, on the street, in a car, getting pulled into a car, strangled by this person who was violent, strong, and really unable to control his actions, probably unaware of what he was doing if he wasn't in this situation. And she was to the point where she couldn't even scream. And we were fortunate enough that someone was walking down the sidewalk and saw what happened and ran into the ED to get help. But that nurse was alone. If that nurse had had a wearable badge that she could have pressed, then it would have alerted her teammates and security of what was happening, and she would have had a different level of help and immediate help. And so when you think about why violence has escalated for healthcare workers, not only do we take all people into our setting, and we are we need to, by law, to take all people who need care into our setting. We're also putting our team members at risk by these types of one-off events where they may be on the street, they may be in the parking garage, they may be pushing a patient to the MRI in the evening through darkened halls. And so when a patient, and I'm sorry to go on so long, but I had the opportunity to speak to a chief nurse at in a hospital system in Michigan, and she told me that since giving the staff wearable badges for safety, that the staff felt so much more protected, and in particular, they felt valued by the leadership because leadership understood that they are being placed in these situations where they're really at a different level of risk than other individuals would be normally in work situations.
Absolutely. Well, just a terrifying story. Thank you for sharing that. And let's in I guess an awkward transition. Let's try to take that story and the mention of technology. Let's move on to this idea that the role of technology can play, and certainly we don't think that technology is the answer to stopping this. And something, Lisa, you just mentioned really jumped out at me is that the health system has to, by law, take all people in and help them. And that's why all of you are here. You dedicated your lives to taking care of others, and you shouldn't be at risk and your personal safety at risk in doing so. Um, Sean jumped into this industry, 6 years ago, as we mentioned. And Sean, we often hear about panic buttons. We hear this from fixed buttons, bedside buttons, things like that. What's a modern wearable safety system like Canopy? Um, why are these different from some of the older, kind of simpler alert buttons, if you will?
Yeah, panic buttons have been around in healthcare for a long time. I think about 6 years ago when we got into this, what we saw were a number of different dynamics that made, what might on surface seem like a simple problem turn out to be actually quite complex. And both Lisa R and Lisa A were really speaking to this nuance that shows up when you're taking care of patients. I think this framework of, you know, is it organic or is it a choice on the part of a patient or oftentimes patients' families, whenever they tend to, or whenever incidences, whenever situations emerge where violence ends up showing up directed towards caregivers. And what we found were a number of things. I think number one, I think just to echo what Lisa A was describing, was there's a real goal to de-escalate. And if you can de-escalate early enough, there's an opportunity to avoid situations that become really dangerous or really threatening to someone's personal safety. While sometimes situations can emerge very dynamically and kind of escalate very quickly, oftentimes there's sort of a burn that leads up to a spot where, tensions explode and things happen. And if you can de-escalate those, you can hopefully take some steps towards keeping your staff safer. Now, how do you do that? I think that's the big question, which is, can you do that, through just words and signs? What we found is that that's usually a good start, but oftentimes you need more resources to apply into situations. And one of the most effective things that we have seen is to be able to dynamically react to an individual and take advantage of the fact that you have many coworkers nearby who might be in a position to help and support you. They might be in a position to change the dynamic in the room. You obviously, larger health systems will have the support of central security who might be able to provide an officer. You might be able to have a dedicated response team. Let's say if you're in a behavioral health unit that might be able to help. The challenge that we saw with most of the technologies was that all of these different resources that are available to an individual, whether it's nearby coworkers or whomever or security, you can never let them know that you needed help without yelling out a code gray or some other, approach that oftentimes would result in escalating the patient further. And so what we found were a number of challenges. So to Lisa R's point, sometimes these situations happen in areas outside the hospital where you might not be able to access, a panic button that is wired to the wall that's sitting in the room. You might have a patient that has you cornered in a room because you happen to walk over to a certain area to do something and you just can't reach the button that might help you get help. And so what we found, in addition to that, was that panic buttons, cameras, other interventions that might be there were just not available everywhere that you might need them. Oftentimes because either they were expensive or just the technology didn't exist at the time that these tools were installed. So what we found was there's an opportunity to make the technology simpler, lighter weight, portable, and ultimately give individual frontline caregivers control over whenever they needed help. And what we found was when you couple that with a lot of the efforts to uh, um, train and educate your staff on how to de-escalate, you could actually make a difference to frontline caregivers everywhere. So if you can give everybody a wearable button, if you can encourage everyone to participate and take advantage of nearby coworkers, if you can encourage people to trigger or signal for help earlier before things get out of control, there's opportunities to de-escalate. And so what we found was that there really was an opportunity to create new technology that took advantage of low-cost approaches to support caregivers all across your organization. And over the last 5 or 6 years, what we've seen is an opportunity to make a dramatic impact to not only individual safety, but also how well supported they feel by their organizations and reducing the anxiety that might come from all these stories that everybody is very familiar with here.
Yeah, that's awesome. One thing that we hear a lot, or that I hear a lot in talking to executives, is many health systems have clinical comms devices, the ability to communicate. But Sean, one thing you said is this ability to discreetly call for help early, right? Early on, the earliest signs of some situation escalating. Um, Lisa A, at Boston Children's, how have you gone about implementing, this type of technology? And particularly, how do you get staff buy-in? Is that a challenge? Is how do you manage that? How can some of the leaders on the call today start to go down that path?
Yeah, I would say a couple of things, Jason, and you're touching on it in terms of this notion of one, I have control. These sorts of wearable buttons, wearable devices give us immediate control, and we can invoke their use when we feel like there could be a problem, not when there is a problem, not when someone else observes a problem, but when I, as an individual, am feeling like I could be compromised, my safety or the circumstances could be compromised, become confrontational. I can control when I call for help. And doing that at the sort of earliest sign means maybe one of my nursing colleagues just walks in the room. And that in and of itself kind of serves to calm. It serves to have another set of eyes on the situation, or another person who's working with me. I don't think it's not that much of a heavy lift for staff, right? I mean, when I feel like I am in control and I have that ability, Lisa said this a bit ago. It's my ability to feel like my employer cares about me. They've made this investment. They've made it a priority that my safety and my ability to have some control over my safety is a top priority. I would say that the case needs to be made, the business case to the executive level leadership, that the investment in the technology is in fact somewhere that the resources need to be committed. And I think getting staff buy-in is not the challenge. It's like everything, there are competing priorities for resources, and how do we make that business case that an investment in wearable technology needs to be factored into our budget process and things of that nature, and really making that case at a higher level.
Absolutely makes sense.
Jason, I would tag on to what Lisa said by saying that my nurse leaders I've talked with have said that the wearable technology is really valued by the team and seems like a no-brainer. And they said that the reason is, and you mentioned staff have a lot of communication devices, but the wearable badges don't need to be charged. They don't need to be docked and charged. They don't need to be handed off to each other. Every single person gets their own. You put it on behind your badge and it's there all the time. You don't have to think about it. So it's really easy. And the training of how to use it for team members, and I'm not talking about ensuring that the infrastructure is put in, and security training is probably much deeper. But for the non-security member team members, the training, my nursing colleagues have told me that it's about 15 minutes for training to know how to use this. And so Sean mentioned being able to discreetly use it. And if you think about how many times you're touching your badge, you're flipping it around, or, you know, you've got your keys back there or something, it doesn't look, it's not this obvious, I'm pulling something or I'm hitting something. And also it's, as Lisa said, it's with you all the time. And so regardless of where you are, you don't have to worry that you're not in proximity of being able to pull the call bell out of the wall if you need help, or getting to the panic button that might just be at the nurse's station. So it really gives the team members a very different sense of being covered with protection.
Absolutely. Okay, we could probably talk, I could certainly talk for hours about technology, but let's jump into some Q&A, because there are some questions in the chat here that I'd love to address. So here we go, rapid fire. We have a question from Joy, and she said, I'd love to hear about how you also manage disruptive visitors and family members, particularly when you're unable to add a flag or a note in the medical record, since they're not a patient.
I can start. We created a code of conduct for visitors. Lisa mentioned that there's an employee bill of rights. We know that for years we've had patient bill of rights, or what patients should expect from us. Now we can also have what we expect from patients as well as visitors. And we implemented a contract. And so what that meant was people sat down with the visitors who were harassing, bullying, intimidating, pushing, violent in some way, and said, we are letting you know that your behavior is unacceptable here. And we understand you're under a lot of stress, and you need to know that if anything like this happens again, you will not be able to visit. Now, sometimes if the event was so egregious, we made the decision to not let the individual back in to our setting. But we had it on paper. The visitor needed to sign the contract, and it was just they got the one-time warning and that was it. If there was another infraction, they were out and couldn't visit again. I think in certain situations, that becomes a little bit more difficult. With adults, it's a little bit easier. With children, if you're telling parents of a pediatric child, you're not going to be able to come back. It's really a difficult situation for both the parent as well as the patient. And so my advice would be many hospitals and different healthcare settings have established what's called a BERT team, a behavioral emergency response team. And it consists of a social worker and a chaplain, sometimes a security person, typically always a security person, except that person may hang outside of the meeting because the presence of a security person may set it all off again. But having a social worker, a chaplain, a nurse, and a physician involved to really sit down, have a calm conversation, outline the expectations with empathy and have the person sign that contract has been very helpful.
Lisa I imagine, as a children's hospital and what Lisa just mentioned, that you all manage this every day. Any tips for how to think about addressing the family members?
I think just reiterating what Lisa said about being clear on the expectations, really, if you can point to something that says, this is our code of conduct and we want everybody to be comfortable in a situation where we recognize there is tumult, there is anxiety. We all need to behave within this framework. It helps and to really just sort of address things with immediacy. These are really hard situations without a playbook necessarily. I think emphasizing the point around the law enforcement and their role and just making sure we have the right representation. And, we've had people just dress a little more informally, right? Because law enforcement can be triggering for some people. And they are a very, very important part of our team and very necessary. And we want to make sure that their ability to be effective as part of the de-escalation team is met with appreciation and not with, some sort of an accelerating moment. So every situation needs to be dealt with, on its own merits with its own circumstances. I've worked in adult environments, acute care, adult level 1 trauma center environments. And there have been instances where we've just needed to ask people to leave immediately because that is much easier in an adult environment. It is very difficult when you're dealing with children and their family members.
Yeah, can only imagine.
Jason,
Well,
I would also add that some states have made violence against healthcare workers a felony. And some states, Maryland, for example, has allowed other people to represent a staff member in court.
okay.
So a lawyer can represent, or a security person or somebody else could represent a team member who's been attacked and wants to take action, but is frightened. And so as we continue to see these kinds of things put into place, team members do start feeling more supported and start feeling like people understand the seriousness of what they face every single time they come to work.
Yeah. It is amazing to me that that there aren't more states doing that. And that sounds like a really powerful thing to empower our healthcare workers to feel safe and report those incidents and not feel like there's going to be retribution. Sean, there's a number of questions in the chat. I'm going to try and summarize a few of them. They're coming at you specifically around Canopy solution and How is it a one size fits all? Do we customize it for different organizations? And specifically, the questions are around the alerts and kind of who gets them and when, and will I get alerts at home? The a whole series of those questions.
Yeah, great questions. And I can see some of them sort of flashing by here. Um, so I think the easiest way to think about Canopy is, I'll just give you a metaphor, which is, think of your credit card. Credit card's a simple piece of plastic that has some numbers on it that you can use everywhere to buy things. And turns out there's really complex technology behind that credit card to make sure it works all the time, that it's reliable, that it can process all the transactions in a way that can be trusted. Well, from a frontline caregiver perspective, what Canopy offers is a simple, portable, wearable duress button, panic button. They, like Lisa R. was describing, you clip it to the back of your badge, but behind that button is a very mature technology stack that ensures that that button is reliable, can be trusted, will work all the time. It will instrument or it's instrumented in a way to provide reporting and analytics that your organization can use to figure out how their response protocols are. And so we've created a lot of technology behind a seemingly simple button that helps hospitals essentially be able to say, hey, we should roll this program out and we should give everybody a wearable button, and we make it easy and affordable enough to do that. And so leadership gets access to insights and data and reporting. Frontline caregivers get a button that they can clip to their badge that doesn't require charging or maintenance, will last you for years while you're working at the organization you're working for. We connect to all of the different applications that you might be using to talk to one another so that your nearby caregivers can help whenever you press the button. They can know that when Jason presses his button, Lisa R and A happen to be nearby. They can get a notification that says, hey, I'm going to help Jason deal with a patient or a situation that he feels might escalate into something that is out of control. And so we like to think about our relationship with organizations as essentially an end-to-end service provider. So all you have to do is say, we're going to roll this button out. The rules are different in this facility compared to that facility in terms of what happens to that button. We'll configure that for you. But the long and short of it is, Canopy does all of the work. Your frontline caregivers get a very simple button, and we create a sophisticated piece of technology infrastructure on the back end to make sure that button can be used to help locate where that individual is in your entire facility, to get you help from whomever might be in a position to help, and do it on a regular 24/7 basis, which is how our hospitals operate. So we try to make all of that as simple and easy. And I think what most of our customers would say is that we tend to have one of the easiest and smoothest implementations around so that you can focus on supporting your caregivers to do what they want, what they are there to do, which is take care of patients.
Absolutely. Well, there's a number of other questions related to Canopy, but I think we'll send some of those answers out in after this. We'll email everyone. But I do want to have one more question. This is a little bit of a, looking into the future as we wind up here. Um, Looking ahead, 3 to 5 years, what do you hope to be true for your staff in this space today? Obviously, we know workplace violence is not going to go to zero, but what do you hope to be true um, for the three of you? Lisa A., why don't you start?
Yeah, I think a couple of things, Jason. I think it's really important to be thinking futuristically, and that this becomes just an opportunity that when you sign up for any healthcare organization, your badge, your first day of work includes a wearable duress button. It's just in there. It's just part of the uniform, if you will. I also strive to create an organization where people feel safe coming forward, where there's both psychological safety and environmental safety, where people can say, this is where we feel exposed, this is where we feel like you as an organization can help, and that we create nimble responsiveness to whatever the emerging challenges are that we end up facing 3 to 5 years from now.
Love that.
And I would add that we would see a decline in workplace violence events. I would say first we would see an increase, because if we're successful in encouraging staff to report, all of the underreporting we are living through right now will morph into reporting. So if we see a spike, that would be expected, in my opinion. But then with the different actions that we're taking, that we would see a decrease. And ultimately, that we would see a decrease in turnover that is related to workplace culture and safety, because we know that our staff are our greatest asset. And we also know that turnover is our most expensive situation. So anything we can do to chisel away at decreasing that turnover, and this is a big one. This is frequently mentioned by team members. Anything we can do not only creates a very different kind of culture, a culture of safety, a culture of appreciation and recognition and value of team members, it also has the real impact of decreasing costs due to turnover.
Absolutely. That we could have we probably should have an entire webinar series on that topic around retention and recruitment. But Sean, your crystal ball, 3 to 5 years.
I'll at the risk of sounding like a commercial, I think there's kind of two things that I'll talk about. I think one is just the role of technology in wearables, whether it's Canopy or others. I'm convinced that workplace violence in healthcare for at least a while longer is going to at least continue to be a reality of healthcare environments. And what we've seen is that a wearable duress button, along with other types of security interventions, but wearable duress button specifically, can become the single greatest intervention to supporting staff and helping them not feel as alone and as anxious whenever they're encountering situations like this. And so over the next 5 years, we anticipate it will be standard issue for individual caregivers to have some form of way to signal for help that can help, support you when you're just trying to do your job. So I think that's, from a technology point of view, certainly what we anticipate happening. I think at a broader level, at a more social and cultural level, my hope, and I think we're seeing some of the initial signs of this, part of the underreporting challenge is really anchored in this aspect of us not talking about this problem. This was something that was not something acknowledged by organizations. It might be something that we didn't necessarily feel was large enough that warranted a broader conversation. But if you just look at the numbers and the impact to our people who might otherwise have entered the profession, that see things like this or experience things like this, we need a robust and thriving healthcare industry. We need people to work in healthcare that are there and enjoy their work so that they can take care of all of us. And so over the next 5 years, I hope that we are part of a mission where we're actually talking about this problem and finding a way to best deal with it, because it's not just a problem that affects our caregivers, it affects all of us when we don't have a strong healthcare system, and our healthcare workers are the heart of how that actually happens. So I feel like we really hope in the next 5 years to go from a quiet problem to something that we're actually talking about, because until we do that, we can't actually do anything about the challenges that our caregivers are facing.
And I would stress that it begins with team members accepting, with team members recognition of this should not be part of the job. We need to move away from that acceptance that we currently have, where team members think this is part of the job of healthcare giving. It shouldn't be. So that is really the springboard that we should be saying within our healthcare environments.
Well
I
said.
think the last comment I would add to that is young people that we're trying to influence about the nobility of a career in healthcare are very much deterred by the stories they read in the news and the headlines that we see. And Lisa, to your point, if we don't start to make it unacceptable, then we're going to lose a whole generation of healthcare workers because they're going to find a safer place to go and to choose a career.
Yeah. Alarming, but I'm very optimistic that this combination of leadership insights and technology and all that we're doing, we can bring this into a manageable place and really support those that are providing care for us. Lisa, Sean, Lisa, thank you very much for the time, and we promised a number of folks, so over 50 of you will receive a $50 gift card for Figs, the brand that seems to be dominating the scrubs industry. Every hospital that I visit seems to be a Figs customer. And so hopefully that is, and if you're a CNO and perhaps not wearing scrubs to work, you can give that to someone on your team. We also would be happy to bring in lunch for your team. Any facility in the country, we do this all the time, and we tend to just do a lunch and learn. It's not a hard sales pitch. It's about creating this culture of safety. We facilitate those conversations. If we can help in any way, we are entirely dedicated and committed to helping our caregivers remain safe. And so we'll bring some evidence-based insights, and really the goal is to boost, staff satisfaction and retention. So you can just send us an email at info@canopyworks, and we're happy to set that up. Lunch on Canopy. And so I'll leave you with why we exist. Canopy is committed to helping hospitals ensure that their healthcare workers feel safe, appreciated, and empowered every day. That is, we live by those three words. We're grateful. We couldn't be more grateful for all of you in this profession. And so we'll end the webinar there. We want you to go about your day, feel safe, appreciated, and empowered. And if we can be of any help in the future, please reach out. Thanks again for everyone joining.